This clinical module is on chronic obstructive pulmonary disease. I'm Mary Liz Doyle Taduni. I'm Associate Professor and Division Head of Nursing at DeSales University. And I'm also a consultant for Alosa Health, providing academic detailing services in the state of Pennsylvania. Alosa Health is a nonprofit organization that's a national leader in developing programs that provide healthcare professionals with unbiased, non-commercial information on the best ways to manage clinical problems. Alosa was established in 2004, and we provide educational outreach services or academic detailing that offer the latest information from the medical literature to help improve patient outcomes. This project is made possible by funding from the Pharmaceutical Assistance Contract for the Elderly, or PACE, and the Pennsylvania Department of Aging. Pennsylvania's prescription assistance programs for older adults, PACE and PACENet, offer low-cost prescription medication to qualified residents ages 65 and older. And for more information, you can see the phone number there. So chronic obstructive pulmonary disease, COPD, is the fourth leading cause of death. And unfortunately, older adults bear an increasing burden of the disease. By 2030, people over 75 will make up over half of COPD patients. And you can see there that it's afflicting males more than females. With COPD, you want to diagnose COPD with spirometry. And the formula for COPD that used with spirometry is it's a ratio of your forced expiratory volume in 1 second, FEV1, over your forced vital capacity, FVC. And anything less than 0.7 indicates COPD. And a significant FEV1 response to bronchodilators suggests asthma, whether in conjunction with COPD or on its own. And asthma is managed differently than COPD. And during the COVID-19 pandemic, there's limited availability of spirometry, but it really should not delay your diagnosis and treatment. So try to obtain the spirometry as soon as feasible. There's 6 non-pharmacologic approaches throughout the course of COPD, and they are smoking cessation, vaccinations, proper inhaler use, pulmonary rehab, exercise and physical therapy, and adequate nutrition. So with smoking, quitting it is the most important point here. And the bottom line is that it's never too late to stop smoking. Figure 10 shows a study that was done back in 1977 that was in the British Medical Journal. And you can see there that at any age, it's never too late to stop smoking. And the sooner you stop smoking, the decreased disability and death will occur. So you have better results the sooner you stop smoking. So getting to the second point, vaccinations. You should get an annual flu shot and also get the vaccine, whether you get Pneumovax once before age of 65 and again at over age 65, or Prevnar. With Prevnar, you want to consider the patients with advanced disease, given the low risk and small incremental benefit with Prevnar. The third point is inhaler technique. This is incredibly important to assess in every patient to make sure that they're getting the appropriate dosage of medicine, and that is how patients are using the inhaler. There's one study that showed that over 75% of patients did not use their inhalers correctly, and then they're not getting the appropriate amount of dosage. So in patients, you really have to assess if the device is correct. Also, there's a really good video, and you can see there the link, that last point, instructional video on how to use inhalers. The fourth point, pulmonary rehab, is such an important part of COPD. For patients with a history of exacerbations or more symptoms with dyspnea, this is really important to start pulmonary rehab. And it is one of the most cost-effective interventions for COPD. evidence has shown that a 6 to 8 week program of twice weekly exercise training can reduce dyspnea, symptoms of anxiety and depression, and readmissions in patients with recent COPD hospitalizations. So the fifth point with exercise and physical therapy, it's really important that patients get both. And again, that should be assessed at every individual patient by the primary care provider, how much exercise and physical therapy. And also adequate nutrition. And also if patients are on particular diets, to make sure they're adhering to those diets, and getting adequate nutrition is essential in patients with COPD. So this is a figure which demonstrates the GOLD criteria. And it shows groups A through D. So A being the least number of symptoms and exacerbations, and D meaning the greatest number of exacerbations and symptoms. And you can see group A, the treatment for group A patients, and you can see at the top line how you have fewer daily symptoms and fewer exacerbations. And we're defining daily symptoms as those defined according to either the MMRC scale, which is the Modified Medical Research Council Dyspnea Scale, which focuses strictly on dyspnea where the scores are 0 to 4, or the COPD assessment tool, the CAT, which includes dyspnea and other symptoms, where the scores can range from 0 to 40. And exacerbations are described as discrete episodes characterized by acute worsening of symptoms, whether that be increased dyspnea, sputum volume, purulence, beyond the usual day-to-day variation and requiring interventions. So you can see with each of the groups A to D. So for instance, with group A, you would treat with a bronchodilator. Group B, you would treat with a LAMA or LABA. LABA is a long-acting beta agonist, and LAMA is a long-acting muscarinic antagonist. And the ICS, which comes in when you look at the group D category, is the inhaled corticosteroid. So this algorithm really shows you how to adjust the treatment for symptoms and exacerbations. For dyspnea, so on the left-hand side, you can see in the blue, the LABA or LAMA. If you start looking at that, it's either LABA or LAMA. And then if symptoms worsen or fail to improve, you would have the combination of the LABA and the LABA. Okay, so this is where you consider the dual bronchodilators. Okay, and that goes the same if someone's on a inhaled corticosteroid on the right-hand side, the green section, where you would have the LABA and the ICS. And then if your symptoms worsen or fail, you would have the LABA, the LAMA, and the ICS. So this is an algorithm for exacerbations. And if for exacerbations are increasing, you want to use the eosinophil levels to guide your treatment. So if you're starting out with a LABA or a LAMA, you want to look at your eosinophils that are greater than 300 cells per microliter, or greater than 100 cells per microliter with exacerbations. And you can see going down the algorithm, if it's yes, you have the LABA plus the ICS. And then if you have additional exacerbations, you would go to the LABA, the LAMA, and the ICS. And then if there are additional exacerbations, you would add roflumilast or azithromycin. On the left-hand side, if your answer is no, you would have the LABA plus the LAMA. And then if additional exacerbations or eosinophils are greater than 100, then you would go to the LABA plus the LAMA plus the ICS, and then add your roflumilast if you have additional exacerbations or azithromycin. So that's a really good algorithm just for exacerbations alone. So here's the point where you have to look at, either stopping or replacing an ICS when it's appropriate. And there is recent evidence showing that ICS does increase the risk of pneumonia. An example of this was seen in the FLAME trial, where patients were treated with an ICS and they had a 50% relative increase in the risk of pneumonia. So you can see that how with similar effective alternative treatments available, ICS can safely be stopped in patients who do not have frequent exacerbations or high eosinophil count. So here you can see if in figure 6, reassessing the need for inhaled corticosteroids. And you have to ask, does the patient have any of the following? Recurrent pneumonia, no clear indication for ICS, or a lack of response to ICS. If those questions all answer yes, you want to switch either a LAMA or a LABA or a LABA plus a LAMA. So at the bottom, you can see in the WISDOM trial, which is in New England Journal of Medicine 2014, that a stepwise taper of ICS did not increase exacerbations. And I wanted to note that one study because it really does just look at ICS. In the evidence, here's an algorithm in figure 7, which shows how to treat exacerbations as an outpatient. And here you can see how you increase bronchodilator for therapy for all patients, whether that be with albuterol and plus or minus ipratropium. And on the left, you can see you prescribe steroids for 5 days. For example, you could use prednisone, 40 milligrams for exacerbations not responding to bronchodilators, plus a short course of antibiotics. And then you want to constantly reevaluate to modify therapy and or hospitalize as necessary. And again, you always want to initiate or adjust maintenance treatment based on the GOLD recommendations that we just talked about. So in patients that have chronic hypoxemia, you want to prescribe oxygen. And the criteria for that is as follows. So those patients who have O2 sat less than or equal to 88%, or PaO2 less than or equal to 55 milligrams of mercury, or a PaO2 of 55 to 59 milligrams of mercury with evidence of pulmonary hypertension, cor pulmonale, or hematocrit greater than 55%, or a PaO2 of greater than or equal to 60 milligrams of mercury with exercise desaturation, sleep desaturation not corrected by CPAP, or severe dyspnea that responds to O2 therapy. And also when titrating oxygen, you want to aim for that O2 sat of greater than 90%. So since COPD is a progressive disease, it's really important to prepare yourself to have those conversations with patients about palliative care. And it's a type of disease that the symptoms worsen, it deteriorates a patient's quality of life. They may have frequent emergency room visits and hospitalizations. Patients with end-stage COPD are far less likely than lung cancer patients to get palliative medicines. And in patients with end-stage COPD, it's been demonstrated that low-dose opioids can help relieve refractory dyspnea without increasing the risk of death. Also, conversations about palliative care should really center around patients looking at enhancing the quality of life, optimizing function, and helping patients and family get the emotional and spiritual support that they need. So here are some final key messages to remember in taking care of patients with COPD. First, you want to use spirometry to diagnose COPD. Second, classify the patients based on daily symptoms and history of exacerbations according to the GOLD classification system, which can guide treatment. Third, adjust the regimen based on daily symptoms and exacerbations. Fourth, for patients who smoke, assess their willingness to quit and tailor recommendations to their stage of readiness. The fifth point is to include non-drug interventions throughout the course of COPD, whether it be recommending exercise, good nutrition, and immunizations for all patients, and then referring your selected patients to pulmonary rehab. And six, to treat those acute exacerbations with short-acting bronchodilators, systemic steroids, and an antibiotic when indicated. And then lastly, begin those conversations about palliative and end-of-life care